We are going to talk about diabetes, and you're going to find some parallelism with Dr. Stephen Piper conference lecture, because, as you know, obesity and type 2 diabetes are very tight, share many risk factors of pathophysiology. And I also will repeat with this pyramid that because it's important to frame this in evidence-based medicine and nutrition, and to distinguish between surrogate outcomes and hard outcomes, and also to stress that evidence-based medicine relies on randomized clinical trials as the gold standard of finding evidence and for the most adequate interventions in healthcare, or rather on meta-analysis of the best quality available evidence. The controversy generally starts with this kind of studies, like the multi-ethnic study of atherosclerosis. This is an observational cohort study with almost 7,000 adults over 45 years old who were asked with a food frequency questionnaire about their intake of diet soda. The study concluded that daily consumption of soft drinks with low-calorie sweeteners was associated with an increase of 36% development of metabolic syndrome and 67 more incident type 2 diabetes compared to non-consumers. So these kind of conclusions and titles in the papers generally arise controversy and fill headlines in the news. And this is a forest plot of some of the more known observational studies, and you can see in your right that the tendency of these cohort studies is to show an increase in the relative risk, in this case, from about 14% of the risk of incident diabetes in the users of soft drinks with low-calorie sweeteners. But basal characteristics of the participants were equal. Did they start equal and maintain equal during the observed period? John Stephen Piper have told about the importance of taking into account the change in consumption during these studies. Will it be that the differences of the groups in their genetic antecedents, BMI, lifestyle, and their environment is relevant? Does lack of randomization that is intrinsic to observational design have an impact in the associations? So are we comparing pears with apples? Look at these characteristics of 5,000 participants free of prevalent type 2 diabetes, according their diet soda consumption. Here are the consumers, and here are the people who already did not consume soft drinks with low-calorie sweeteners. Basically, you can observe a difference of 2 points in BMI, a difference of 5 centimeters in waist circumference, and almost 200 calories per day in their daily intake, who are, besides their consumption of low-calorie sweeteners, in more risk to have incident type 2 diabetes or obesity. The conclusion is quite simple. The participants who are in the red box. And so you can see that there are different and there is a statistical difference in the groups, and we are not comparing the same kind of patients. So it's not surprising that we can have results that suggest the increase of type 2 diabetes. You have seen also this meta-analysis of Imamura of observational studies also. You can see here a 25% increase using the crude data. But when you adjust for adiposity to reduce the bias of confounders, in this case, BMI, waist circumference, you will see that the relative risk is reduced to just to 8%. And what would happen if we adjust, for example, additionally for their calorie intake difference? The significance is reduced to 0. And if you see more than half of these studies lost statistical significance when we adjust for adiposity and obesity. So these studies can have high possibility of confounders, and cohort sets a statistical association, but not a cause-effect relationship. And it was mentioned that the reverse causality is one of the most important explanations, because people with more risk factors for type 2 diabetes, like being obese or having a diet which more caloric intake, has more possibility to have diabetes, and they are using low-calorie sweeteners as a tool to counteract their obesogenic lifestyle or their risk factors that they already have. But not all the observational studies shows this tendency. This is an enhanced survey that comparing to water, the low-calorie sweeteners, and they found that low-calorie sweeteners were associated with reduced intake of carbohydrates, and also that there were no impact in HbA1c or insulin sensitivity measured by HOMA index, with similar glycemic responses comparing to water. So let's look some randomized clinical trials. We have to say that even they have advantages, they also have some disadvantages. Generally, they are shorter, cannot keep control of the diet for a long time, and they cannot have the captive population for years than do the observational studies. One of the controversies was related to the possible impact of low-calorie sweeteners in gut hormones. You can see with this study of Rebecca Brown how she found giving a preload of soft drink with low-calorie sweeteners an increase of GLP-1. As you know, GLP-1 is an incretin that is important for insulin release and glucagon suppression. And as you know, these GLP-1 analogs and GLP-1 based therapies are used precisely to prevent, to treat obesity and also to try to treat diabetes. So it was quite curious that some papers speculate about the possibility of GLP-1 as being having a cause in producing obesity of type 2 diabetes. And also, it's important to notice that this was not the same effect in healthy people, type 1 diabetes, and not seen in type 2 diabetics. So it was not an homogeneous effect. But also, if we go to other clinical trials, not all found this GLP-1 elevation. what was consistent in all randomized clinical trials looking for this is no elevation of glucose, C-peptide, or HbA1c. And the GLP-1 effect was not observed in some of these studies. This is another study from Jing Ma. And comparing to sucrose, you will see that both incretins, GIP and GLP-1, are not increased in this population that was done in healthy subjects. So most of the experts in the scientific community agree that even there are sweet receptors in gut and in tissues, in experiments in cells and in tissues, in vitro studies have been shown an increase in GLP-1 production and also in transport in glucose. It doesn't seem to be translated in increase in insulin, glucose, or hard markers or of glucose metabolism. Here you can see a systematic review of randomized clinical trials looking to endpoints related to diabetes. What they find after selecting from almost 4,000 publications, 53 randomized clinical trials, a reduce in energy intake versus sucrose, no effect on HbA1c, HOMA index as a marker of insulin sensitivity, and no effect in lipids, no effect in hypertension. So what we have seen there is a neutral effect. Here, this is a short study clinical trial by Dr. Stanhope, and she gave these patients increasing doses of sugar, high fructose corn syrup, from their calculated daily energy requirements. And what you can see here in the black bars is the use of aspartame substituting the high fructose syrup. And these are markers for cardiovascular risk factors like non-HDL cholesterol, LDL cholesterol, and apoprotein B. And in all cases, you can see an increase of the deltas of these markers of cardiovascular risk, but none in the aspartame group. Does it mean that there is a cardioprotective effect of low-calorie sweeteners? Of course not. You won't see a cardioprotective effect. It's just the impact of the reduction of sugars in the diet, not an intrinsic effect of low-calorie sweeteners. Here, again, other systematic review of 41 randomized clinical trials studying the effect of low-calorie sweeteners on acute glucose homeostasis. Again, no different than water, no deterioration of glycemic markers, and when comparing to sucrose, there is a modest reduction of plasma glucose that not should be attributed to the intrinsic effect, but just to the replacement of sugars that is done in this kind of trials. Here, you can see this is a 3 months randomized clinical trial investigating the potential for sucralose to affect glucose homeostasis. And you will see no difference in the control group with the sucralose 1, and also both in the plasma glucose and also in the oral glucose tolerance tests during the duration of the trial. Moreover, there are some studies that show light reduction in glucose, especially with stevia. But it's important to notice that this trial, and as others that have reported reducing blood sugar and hypertension, are made with the crude leaf of stevia, not with the commercial purified steviosity that in general shows a neutral effect, as do the other low-calorie sweeteners. Recently, this was published this year, is another meta-analysis looking for acute short-time effect in plasma glucose, and also the glycemic impact did not differ according to the type of sweetener, and there is no increase in the glucose levels. But if you review also longer time studies, the constant is that these studies, like this one, double-blind and crossed, 50 non-diabetic adults, acesulfame and aspartame versus not sweetened drink for 3 months, you will see a total non-significant difference in the markers related to insulin sensitivity, like Matsuda, HOMA index, insulogenic index, and also in the markers of secretion of insulin secretion. We are doing a work for who is going to be published by the end of this year for the Latin American Diabetes Association, and our group identified 33 RCTs evaluating glycemic effects of low-calorie sweeteners, 25 studies not showing significant change, 5 studies with slight improvement in glucose levels. Adding both groups, we have 21 with neutral or favorable effects. In 3 of them, there was a slight deterioration in glucose levels. But if we see 2 of them, Pepino and Romo, used commercial sucrose added with dextrose. One is with very obese woman, and the other one is a recent published also this year. Is a 2 weeks trial, a controlled trial, but also use about 8 to 10 sockets that use commercial dextrose as a carrier of the Splenda sucralose sockets. And the other one, I'm not going to go in deep for this because the next speaker is going to talk about it surely, is the Suez that is just 7 participants without controls, very high saccharin doses in the limit of the ADA and with many methodologic critics that are going to be surely explained. And finally, I think I'm the third or the fourth in this day to present this conclusion of American Heart Association jointly with the American Diabetes Association. That is not very different from the one that was published in about 6 years ago. And they should say that for adults, this writing group concluded that these low-calorie sweetened beverages may be a useful replacement strategy. They make a warning about the long-term use in children. And if you see for the evidence, it's not because there is evidence of any deterioration, it's most because a speculation about the long-term effects of sweeteners, of sweetness in children. But at the same time, they say that in diabetic children, then they are going to be probably the children who is going to be more exposed because the nature of the disease. They also suggest that can be used as a for substitution in preventing excessive glucose excursions. So in general, we can agree that the strong evidence with hard outcomes and with highest levels of evidence suggests that there is no effect in glucose levels per se, intrinsic effect, but can have a modest effect substituting and reducing sugars, replacement, simple sugars. Thank you very much.